Welcome back, or welcome for the first time to day 2 of the Riley's Wish lecture series. My name is Jason Callis, and I am the Assistant Director here at the Center for Young Adult Addiction and Recovery at Kennesaw State. It's my pleasure to welcome you to our presentation today by Lauren McMeekin, the role of purpose in the treatment of OCD and substance use disorder, seeking meaning, finding recovery. A little background, when Margaret suggested Lauren come speak for us, I was able to find a number of her presentations and talks online, and I was very impressed. I was able to have the chance to connect a handful of times pre-series, and just her passion and drive for this work was very evident just in our brief conversations, and her heart for serving this population was very, very clear in our conversations. Lauren is a licensed marriage and family therapist. She practices mindfulness-based cognitive behavioral therapy with a focus on exposure and response prevention and acceptance and commitment therapy. Lauren's focus has been on the treatment of OCD since she returned to graduate school in 2014. She began working with the OCD Center of Los Angeles in 2016 and still practices out of their Newport Beach office. In addition to her work with anxiety disorders and obsessive compulsive spectrum disorders, Lauren treats people struggling with body-focused repetitive behaviors, eating disorders, and body image issues. She's a certified intuitive eating counselor and has received training in enhanced CBT for eating disorders. I really look forward to Lauren's presentation this afternoon. And with that being said, I will hand the mic off, so to speak, to Lauren.
Well, thank you so much, Jason. I really appreciate it. I'm so grateful to be here and to have the opportunity to speak with you all today. As Jason said, I do work with all of those different disorders, and I do also work with co-occurring substance use disorder. And it's this overlap between OCD and substance use disorder is a passion of mine, not only from a clinical vantage point, but also because of my own personal lived experience. So I have been sober for almost 16 years in June, and I have been in recovery from OCD for over 10 years now. And so this is a topic that is near and dear to my heart. Before I forget, let me go ahead and start sharing my screen so you guys can see that. So the talk, everything good? The talk I'm going to be giving today it was inspired by a conversation that I had with Margaret Sisson, who is the mother of Riley Sisson and the founder of Riley's Wish. And as Jason mentioned, the series here is in honor of him. He struggled with both OCD and substance use disorder and tragically lost his life to an accidental overdose in 2014. And in that conversation, Margaret shared with me this wonderful article that he started before he died, and that Sarah Janicki and Ethan Smith finished after his passing. And at the end of the article, he was talking specifically about the role that service work plays in recovery from substance use disorder and the importance of that, and also how that might be applied in the realm of OCD and OCD treatment. And this really struck a chord with me because I can certainly speak from my personal experience here that being of service has been incredibly important, not only on the substance use disorder end of things, but also in my recovery from OCD. In fact, in many ways, it's informed my career choice. But in addition to that, there's so much anecdotal evidence of this in our field. A lot of people who advocate for OCD and seem to find it to be a great support in their own recovery. In fact, there's a beautiful quote I want to share that Riley included at the end. It says, it's actually Michael Janicki quoted saying, "In working with OCD patients since the late 1970s, I have seen some remain very ill Thousands of patients get moderately better, and a few make dramatic strides and totally reclaim their lives. It has seemed to me that the ones who do best are those who feel obligated to give back and help other patients. Somehow, this drive to help others energizes them to fight off their own OCD and stay well and productive. So, what I wanted to do is sort of continue the conversation that Riley started. And I wanted to build on that conversation because I think that this service work element that is so meaningful in both realms is sort of under a larger umbrella overall, which is this umbrella of meaning and purpose and goals and values being a driver of recovery. But before I get underway with all of that, I do want to start by just talking very briefly about what OCD and substance use disorder are. This is probably going to be a review for many of you, but we have a pretty wide range of people in the audience today. So I want to get everyone sort of on a similar page. So OCD is a disorder that is characterized, not surprisingly, by obsessions and compulsions. And obsessions are upsetting, unwanted, intrusive thoughts, images, or urges that occur in a person's mind. And they are very distressing to most. They cause anxiety for those who suffer with OCD and lead people to do compulsions, which are behaviors that are they're aimed at specifically reducing the anxiety that was caused by the initial obsession. Right? We often think of people who have anxiety thoughts or worry thoughts related to germs, having anxiety and washing their hands to alleviate the distress. The reality is, in order to have OCD, you don't have to have obsessions and compulsions. You have to have one or the other. And sometimes the compulsions are done just according to rules that have to be followed rigidly, not in order to address a particular concern. I do want to take a moment briefly to talk about these pure OCD variants, which it's sort of a colloquial term that we use in the field to talk about types of OCD that are, they don't have as many of the overt compulsions like that hand washing I was just talking about. And we do really think of that stereotypical vision of OCD when we hear about it in general. So important to highlight this. There are lots of ways in which this can show up, but usually it's intrusive thoughts come in about something that's deeply upsetting. So this can come up in terms of questions of identity, questions of whether or not you want to harm people. So if you have an intrusive image of harming your family, for instance, that, you know, you might start to have anxiety and then do all sorts of compulsions to make absolutely sure that you don't want to harm your family. And to be clear, these people have no intention of harming anyone. But I want to talk specifically today about an example from my own lived experience with, because it relates to this overlap between OCD and substance use disorder and how they can really inform one another. So when I first came to treatment for OCD, I'd been sober for several years. And I started to have obsessions about whether or not I had relapsed by eating a piece of tiramisu. And for the better part of 2 years, I spent countless hours analyzing, ruminating, trying to figure out whether or not I had relapsed, asking pretty much anyone in 12-step, which is where I got sober in AA, whether or not they thought I'd relapsed, whether or not I needed to reset my sobriety date. And it didn't matter, there was one point at which I thought, okay, I'll just reset it, but it didn't stop the back and forth. So this obsession, these thoughts that came in like, well, what have you really at your core intended to get drunk by eating that piece of tiramisu, was followed by a lot of anxiety and compulsions. So as I was saying while describing it, a lot of these compulsions didn't look like your traditional hand washing. They looked like a lot of avoidance of situations in which I might be exposed to alcohol. So I would, even at parties, I'd maybe even avoid eating things because drinks had been passed over them. In terms of reassurance seeking, which is another category in which these compulsions can be made manifest, I found myself asking people to try my drinks to make sure that there was no alcohol in them. And as I said, I spent so many hours trying to analyze my intentions or my memories to try and figure out whether or not I'd actually relapsed on that piece of tiramisu. And even though I recognized at the time that it was very, very excessive and that it really didn't matter as much as I was placing my attention on it, it still really consumed me. So that's pure O. I mean, one example. There are so many. I mean, the human mind can come up with so many areas to be anxious about, and this is really just one, but it is certainly pertinent to our conversation today. So in addition to having obsessions and compulsions, they have to be time consuming. They have to cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. And the symptoms can't be attributed to the use of a substance or to another medical condition or a mental health condition either. So substance use disorder is essentially a problematic pattern of use. And so when we diagnose substance use disorder, whether it's alcohol use disorder or marijuana use disorder, that we're looking at a list of different symptoms that one might experience. I've listed some of them here. They're quite extensive. So people have to meet an amount of those in order to receive the diagnosis. But it includes things like spending a lot of time obtaining and using and recovering from substances, not engaging in other meaningful activities, being incapable because of substance use to fulfill major role obligations at work, at home, and experiencing things like tolerance or withdrawal. So that's sort of a picture of these two disorders. And why is it important that we talk about these two disorders together? It might be self-evident just in that we're here today because people do lose their lives to each of these disorders, really. But this can ultimately lead to death. So it's important to talk about to save lives and to alleviate a great deal of suffering. And there is so much overlap. Depending on the research that you read, like a clinical sample of individuals with OCD were found to have a 27% co-occurrence rate of substance use disorder throughout the course of their lifetimes. A study with veterans found that of those with OCD, 36.7% also had substance use disorder. As you can see, several other studies, 17.6 to 26.5% of people who had OCD also had drug abuse or dependence, and likewise 24.1 to 38.6% of people had OCD and alcohol abuse or dependence. There's a lot of people who struggle with both. And these numbers, if anything, are likely to be underreported because of the fact that people will sometimes be denied treatment for the OCD because of an active substance use disorder, which is considered to be primary, like that it needs to be addressed first. But as I just mentioned with the example that I gave around my own personal experience, these disorders inform one another, and not just in that way. Of course, that's one specific way. There are a number of ways in which obsessions can hook into recovery, and also because of obsessions and the anxiety that they cause, a lot of people with OCD have substance use disorder largely because they're self-medicating, because they have difficulty navigating the presence of the obsessions and the anxiety. So it's really important that we talk about how to treat these two disorders together. And at present, there's not one single or even one recommended way to treat both concurrently. There's not like a treatment protocol for both. So what I wanted to discuss, as I mentioned before, is this piece about meaning and purpose and how they can inform recovery from both disorders. But to that end, we probably should talk about what they share, what these two disorders share in common. And one of the central features that drives these disorders is something called the pleasure principle, a term coined by Sigmund Freud. Very, very simple at its core. The idea is that humans want to seek pleasure and avoid pain at all costs, and that's a primary drive for a lot of people. And we really do see this informing substance use disorder and OCD pretty significantly. And you can see them playing out through what's called operant conditioning. So you probably have heard of positive and negative reinforcement and positive and negative punishment. This is all under the heading of operant conditioning. And just to sort of get a little bit further into that, positive reinforcement, actually positive has nothing to do with good or bad. It's about when a behavior is done, something is added to the circumstances. So if a trainer says sit and a dog sits down and a treat is given to the dog, that's reinforcing. That's where the reinforcement comes into play, because it's positive, because it's perceived to be a positive experience. It reinforces the behavior ongoing. And likewise, negative reinforcement is about removing something unpleasant from the circumstances and that reinforcing behavior. So if my head hurts and I take an aspirin and I feel better, I'm more likely to take an aspirin the next time that my head hurts. The behavior is reinforced. And when it comes to OCD and substance use disorder, we see positive and negative reinforcement informing substance use disorder. So for anyone who's ever used a substance, or yeah, you can probably understand how positive reinforcement works. The idea being that if I don't know, smoke marijuana and I feel a sense of euphoria, or if I drink alcohol and I feel a sense of confidence, or I use cocaine and I am better able to focus my attention, that I'm more likely to use these substances again because of the direct benefits that I experience from these substances. Likewise, people continue to use substances because of negative reinforcement. The idea being that people are trying to avoid the negative consequences of stopping use. Things like the experience of craving. Right? When somebody stops using, they tend to have an increase in craving for the substance. They may experience withdrawal. And in addition, they may be trying to avoid having to deal with some of the negative repercussions that have occurred as a direct result of use. So things like interpersonal problems, problems with the law. So continued use sort of allows people to put that out of their minds. So that's how the negative reinforcement plays out in substance use disorder. When we talk about OCD, we're really looking at negative reinforcement as opposed to positive reinforcement. The idea being, like I said before, if somebody has an obsession, like, oh my gosh, what if I relapsed? What if I really wanted to get drunk on that piece of tiramisu? And that causes anxiety or distress. Then the compulsion that one might do is in order to try to alleviate that distress and that anxiety. And the trouble is that sometimes it works. Sometimes by doing the compulsion, at least temporarily, the anxiety reduces. Not always, and sometimes it ends up re-triggering a person when doing a compulsion. But the fact that it sometimes does remove this piece of discomfort and doubt and anxiety makes it so that the next time they have the obsession, they know that, oh, I should do the compulsion again because that's what's going to help. So people with OCD engage in compulsions and experience negative reinforcement because they're trying to avoid and successfully in moments avoiding thoughts, feelings like anxiety and uncertainty about the future. Now, of course, the uncertainty is still there, but there's this perceived sense of certainty that can come with compulsing. So, looking at how the pleasure principle applies to both of these disorders, it becomes clear that the pleasure principle drives the problematic behavior. The pleasure principle is actually the issue, because by virtue of the fact that people are prioritizing experiencing pleasure and avoiding pain, they're actually continuing to use substances that are interfering with their lives and continuing to do compulsions that are interfering with their lives. So the pleasure principle doesn't really have our best interests at heart. And so if this isn't the priority, if this isn't the thing that everyone in recovery is focused on, right? Like that's certainly what is the primary focus when somebody's in a disorder, then what can we focus on becomes a central question. And that's where meaning and purpose come into play. I think Viktor Frankl said it best when he said, "He who has a why to live for can bear almost any how." And when it comes to the treatment of both OCD and substance use disorder, these treatments are not for the faint of heart. It is very, very difficult to, not impossible by any stretch, but it is challenging and harrowing to undertake recovery when it involves reducing or getting rid of the thing that in a substance that has been like helping. And same with compulsions, right? We're in our work with OCD, the gold standard treatment is exposure and ritual prevention. And the idea is that we're asking people to face their greatest fears and do absolutely nothing to protect themselves, or at least to give themselves the perception of protection. This is not easy. So we need a why. We need something that supersedes this pleasure principle in order to drive recovery. And I will say that Viktor Frankl is a very reliable source when it comes to this. He actually survived many years in a Nazi concentration camp, and he wrote a book afterward called Man's Search for Meaning, about how he found meaning and purpose and how they helped him through his experience in a concentration camp. So this why can be really, really important. When we talk about meaning, I'm going to be sort of using this definition here, but I'll be talking about meaning, purpose, goals, and values somewhat interchangeably, not that they're the same thing, but that they're all sort of part of the same family. So we're talking about meaning as an individually constructive cognitive system that is grounded in subjective values and capable of endowing life with personal significance and satisfaction. I really want to highlight the subjective piece here. We're going to be talking about some specific methods of supporting this cultivation of meaning with people who have OCD and substance use disorder. And there isn't one value that brings meaning to everyone. It is highly subjective. So I do want to start the conversation by taking off where Riley left off with this discussion of 12-step treatment of substance use disorder and this element of service work. So for the record, 12-step treatment is an evidence-based, peer support, because it's not treatment per se. Attending meetings one or more times weekly is associated with prolonged abstinence. And actually, in some instances, 12-step programs have been proven to be more effective than treatment, than therapeutic interventions. So, and this is important because AA exists in 180 countries, is donation-based, and is readily available for individuals. So it's certainly not the answer for everyone. And there are other answers. There are other things like smart recovery that are great adjuncts. But at the very least, this is a readily available resource. And certainly some of the tenets that it talks about are helpful in recovery from substance use disorder, but also can help, at least anecdotally, with OCD. So this focus on service supports recovery in a couple of ways. First of all, when people first present to recovery, and again, from lived experience, I can certainly sort of reinforce this, that people are feeling pretty dejected. They don't feel like they have much to offer. It's usually a pretty low point in existence. And so what service work can do is lead people to feel like at least they have something to offer. And it may be small, it may be something like a commitment at a meeting where you're shaking people's hands, well, at least pre-COVID times, on coming into the meeting, or handing out chips, or even giving cakes for people who, that's a tradition here in California anyway, that celebrating anniversaries with cakes. So it can give people a sense that they can at least show up and do something. They have some sort of purpose when they don't feel very useful. They're sort of at the lower point of their existence. And it it's not just the sort of overarching that service work is encouraged, but it's actually the sort of pinnacle of the steps. So the 12th step states, having had a spiritual awakening as the result of these steps, we tried to carry this message to alcoholics and to practice these principles in all of our affairs. And again, being able to show up for another individual can be very personally meaningful. Not only that, but by showing up for people who are still struggling and with something that perhaps you've overcome to some degree, or even when you're brand new, it imbues your experience and the challenges that you faced with meaning inherently, which is important because a lot of people may look at their experience and think, oh my gosh, I wasted all this time. I can never get it back. I'm a horrible person. And instead see, okay, well, this is something that I can use to help somebody else. So there are, as I mentioned, a lot of ways to be of service in 12 step, including commitments at meetings and sponsoring people and working with them through the 12 steps. But it doesn't just end there. And certainly this idea of service work extends far outside of the rooms of AA meetings. And this is where I think with OCD, it can certainly be a support. Riley mentioned in the article that there are lots of conferences that you can go and speak at, which is a great method of being of service and bringing your own experience to bear and to support your own recovery. And like I said before, there are lots of advocates who seem to get a lot out of working with others and sharing their own experience. But 12 step actually speaks to meaning in a larger context as well that I wanted to touch upon. So the sort of underlying issue from a 12 step perspective is this idea of a spiritual malady. So people are drinking and using because they have this sort of spiritual void. And oftentimes in the context of 12 step, we do think about this idea of God or higher power. In fact, in the second step, it says, we came to believe that a power greater than ourselves could restore us to sanity. But the reality is that need not necessarily be related to God or to some sort of sentient being that is overlooking existence or even sort of pulling somebody into sanity. This could be meaning, right? And I think when we talk about a spiritual malady, it is a lot about having a more hedonistic approach to life, very much based on this pleasure principle of I just want to make sure that I feel as good as I can and that I don't feel badly. And so really, if we look at this idea of a power greater than ourselves, this is anything that is greater than us individually. And so looking at this idea of meaning, really, it's throughout the program, even though oftentimes it's referred to in the context of a higher power or God. So in addition to 12 step, I want to talk about two other treatments that are evidence-based for both OCD and substance use disorder that can support recovery, again, because treating these things concurrently is so important. And both of these treatments really do focus on this topic of meaning and values and goals and purpose. And those are motivational interviewing and acceptance and commitment therapy. So starting off with motivational interviewing, the general idea of motivational interviewing is that you're trying to elicit from the individual basically their why. You're trying to ask questions and explore ambivalence in a way that helps people to recognize what it is that they want to do and why. And it's probably a good moment to say that I hope that, if nothing else, as you walk away from this talk today, I hope that you take with you a couple of concrete skills that you could use as a therapist, as a loved one for somebody with OCD or substance use disorder, or as someone with the disorder. We'll be talking about even more than the 12-step elements that I already talked about, uh, some concrete ways, and that's the important element here is how can we really support people in the recovery process. So, like I said, motivational interviewing really about eliciting it from the individual. It says here, focusing on values can help clients define the kind of life they want to lead and the kind of person they want to be, thus fortifying their determination to make adaptive changes. Really back to this idea of he who has a why to live for can bear almost any how. So in terms of the evidence that exists, there's plenty of evidence suggesting that motivational interviewing is an effective treatment for substance use disorder. In fact, a meta-analysis of 59 studies showed that motivational interviewing supported recovery and that it wasn't statistically significantly different in terms of the outcome when compared to treatment as usual, which means that it's about comparable to the treatments that also exist for substance use disorder. When it comes to OCD, motivational interviewing can be used as an adjunct to ERP because ERP is a highly effective form of treatment. The trouble is that not everyone completes ERP. So we look at this number of 71% efficacy rate of treatment, but when we take into account those who don't complete treatment, that's 52%. So there are a lot of people who are not getting the full benefit of treatment and who are not recovering. They've done a number of studies using motivational interviewing, and one study showed that when given a course of motivational interviewing, a group of individuals who had previously declined treatment or dropped out of treatment for exposure and ritual prevention, of those, 86% decided to undertake a course of ERP. And while 50% of those people did drop out, 50% of those people stayed in through the course of treatment and had comparable outcomes to those who had never dropped out of therapy. So that's pretty impressive stuff. Again, another study shows that 5 of 6 subjects who had previously dropped out of ERP, they completed treatment after having a course of motivational interviewing, and all 5 showed symptom reduction. So there's certainly some promise here. So what is motivational interviewing? The idea is to help people work through the stages of change. So this is called the trans-theoretical model. The idea being that individuals walk through different stages on the road to recovery. Some are in the pre-contemplation phase where they're not even thinking about discontinuing use or stopping compulsions. Contemplation is where one starts to think about, well, maybe I do want to consider some sort of change. And preparation is where you're starting to outline how you might do that. Of course, action is pretty self-explanatory, as is maintenance. So we're trying to move people through these stages toward action and maintenance to support recovery. And motivational interviewing does this in a number of ways. They really love their acronyms. So one of those acronyms is OARS, which stands for open questions, affirmation, reflective listening, and summary. And the way this works is so open questions are questions that don't really have a yes or no answer. So they invite exploration of ambivalence. So asking questions like, well, what is it that you want from this process, whether that's in the context of OCD recovery or substance use recovery? What do you want? Do you want to stop drinking? Do you want to reduce your drinking? And just trying to help people to consider what it is that they want to do. And we'll build on this a little bit later. Affirmation, which includes essentially highlighting where a person is doing well and their strengths, reflective listening, which involves uh, essentially encapsulating and reflecting back what you've heard an individual say. And that can sometimes include adding on to what the individual has said, or perhaps making an extrapolation that can be considered between you and the other person, therapist and client, in the context of therapy. And it can be helpful because it helps people to hear back what it is that they're saying, but it also helps to see, oh, look, I am ambivalent about that, if that's what's reflected back. And then summary, which is essentially trying to synthesize all the ideas and again reflect that back to the person so that they can really hear what it is that their thought process is and whether or not they agree with it ultimately. So open questions and affirmations and reflective listening and summary are used within the context of darn cat, again another acronym, but these ideals are used to elicit what they call change talk, which is talk toward change, unsurprisingly. So the idea being that if we can highlight an individual's desire, ability, reason, and need, that they're going to start to ultimately engage in change talk around commitment to taking action, activation, taking steps. So I want to talk a little bit about desire, ability, reason, and need, with a special focus on reason, because this is really the element of meaning that we've been talking about or focused on. So desire, if we were, let's say we're to use an open question to highlight desire, it's kind of like what I was saying earlier. Well, what is it that you want? What is it that you want to happen in the future? How do you want to see your life unfold? Ability, which is like, well, how would you do that? How would you make the choice not to drink for one day? How would you make the choice to disengage from some sort of compulsive behavior when you were feeling anxious? Reason is really about the why again. So highlighting, well, why would you do this? Why is it that you would undertake something as challenging as facing down the things that give you anxiety? What's the important thing that you're going to get out of this? And same with, why would you want to discontinue drinking? What do you stand to gain here? And then need. How important is it to you to change? How important is it to you that you stop compulsing or stop using or reduce using? So in terms of what studies have shown with a substance use disorder, elements that have been proven to be tied to recovery are change talk, like we were just talking about, eliciting change talk through that darn cat acronym, and then developing discrepancy, which is just highlighting the difference between how things are and how you would like them to be. And this is really predicated on meaning as well, right? That this is the sort of meaningful goal that you're looking toward versus where you are right now, and seeing the differences as a motivating factor to make change. With OCD and motivational interviewing, I thought this quote was helpful to illustrate. Motivational interviewing helped address whether the advantages of change in OCD symptoms outweigh those of sustaining the status quo. Here, what seemed helpful was eliciting what values the OCD behaviors reflected and contrasting those with the values that could be expressed if the OCD behaviors were reduced. The recognition that giving up OCD behaviors was not just compatible with, but facilitative of living out cherished values appeared to fuel the desire for change. So again, you can see here that the ability to highlight how OCD might interfere with and sort of connects to both developing discrepancy and eliciting change talk, looking at what life with OCD is like and what life without the compulsions would be like, contrasting the values that could be expressed in either circumstance and recognizing that perhaps discontinuing compulsions is going to be more facilitative of taking valued action. So I want to switch to talking a little bit about acceptance and commitment therapy. So studies show that it is an effective treatment of a substance use disorder, including a meta-analysis, a study comparing ACT and treatment as usual, a control trial, a systematic review. For those who are interested, I do have slides for this presentation that have all of the references, as well as an extensive reference list. So I'm happy to share that after the fact. And in terms of OCD and acceptance and commitment therapy, research also shows that ACT is effective in treating OCD. In fact, a meta-analysis actually found that ACT is equally effective to CBT, which is, CBT is the cognitive behavioral therapy, and the behavioral piece is exposure and response prevention, or ERP. So that's quite a big deal. As I mentioned, it's considered the gold standard of treatment in therapy for OCD at present. So I want to talk about these 6 core principles of acceptance and commitment therapy, again, with the hopes of providing some ideas for practice or even for supporting yourself or loved ones. Acceptance is the initial piece, which involves accepting the presence of unpleasant, unwanted internal or private experiences like thoughts, feelings, urges, and sensations. So that might look like, for somebody with substance use disorder, accepting the presence of uncomfortable urges. And for somebody with OCD, it might look like acceptance of the presence of thoughts or the presence of anxiety. And for somebody with substance use disorder, it could easily look like, I'm going to accept the presence of this sadness instead of turning to a drink. So many ways in which this can apply, and really viewing these things through a lens of non-judgment. So this is a very mindfulness-based therapy. So being able to recognize, oh, I'm having a thought, I'm having a feeling, and not necessarily saying that's good or bad, just making space for and accepting. Cognitive diffusion, which involves the ability to see a thought as a thought instead of as a fact. They have a number of analogies like and ideals that one can use, like viewing a thought as though it were being projected on a screen in front of you. It's the idea being that these are words, they are stories, and they may be factual, they may be not. So to introduce a little bit of space there, being present. So and just in terms of cognitive diffusion and how that could support OCD and substance use disorder, the ability to see, oh, I'm having thoughts related to relapsing on tiramisu or harming my family, any of those types of things, and not necessarily taking them seriously. It doesn't mean that your anxiety isn't going to go up, but having the space to see them as words. And with substance use disorder, that could look like recognizing that thoughts like, oh my gosh, how am I going to make it through the day without drinking? That those are words, those are thoughts. They're not a reality. And it sort of ties into being present, right? And at least in that particular example, coming back to the here and now. This is especially important for substance use disorder, and especially in the 12-step context with one day at a time. It's very much about being present. Like, I just am going to stay sober for this minute right now. That's all I have to do, or this hour, or this day. And likewise, being present really informs the treatment of OCD, in that the tendency is to get lost in compulsions. And this is especially true of mental compulsions. The ability to really infuse yourself in the present moment, to connect with the world around you, is supportive of making the choice not to actively engage in trying to figure out the obsession and to try to alleviate the anxiety. Self as context is really about the idea that all of these internal experiences are happening within you, that none of them are defining of you either, is an important piece here. So, okay, I'm the sort of entity or self, I suppose, that's housing the feelings right? The emotions, the cravings for alcohol, the thoughts, the intrusive thoughts with OCD, or even the physical sensations of anxiety. So, in terms of where meaning and purpose come into play, values and committed action are really central to this. So, in acceptance and commitment therapy, mapping out an individual's values and clarifying them so that they can take committed action in line with those values is really central. So it bears briefly talking about what values are and how to sort of sort them out so that they can inform behavior. When we talk about values, in the context of values versus goals, goals are really something that you can achieve, that is, that you can sort of check off a checklist. Like, I'm going to get married, or I want to have a family. And values are ideals that you can bring to any situation. Ideals like love, right? I can bring the value of love to any situation, and it's not like it's ever checked off. It's not like, oh, I was loving this one time, so I'm now done. It's much more about this ongoing um, infusing of these ideals into life. And so, some ways to support people in exploring this, and perhaps even uh, yourself individually, if you are struggling, is to consider, well, what do I want to stand for in this life? What is it that is meaningful to me? What is it that I want to be remembered for at the end of my life? So, even considering what you want said in your eulogy, that's a technique used in acceptance and commitment therapy, and not intentionally in a morbid way, but in a way of really outlining, well, what are the things that I aspire to here? And not that anyone is ever going to arrive at living a fully values driven life. That doesn't exist. We act in ways that are inconsistent with values all the time. If any of you have ever driven on the 405 freeway, you can attest to this. I know a lot of you are in Georgia, so forgive me if that's not necessarily something you can relate to, but a lot of traffic, essentially. So it's not that we have to arrive there. It's about having these ideals and then trying to prioritize actions that are consistent with these ideals. And you can see where, in our discussion of the pleasure principle, this is really about prioritizing these things over the feelings that we're accepting, right? Those thoughts or those feelings or those experiences that we either want or don't want. That instead of highlighting that, we're really highlighting the kind of life that we want to live, which is ultimately quite fulfilling. The beauty of acceptance and commitment therapy is that they're very open source. So they like to share their materials. And so all of this, well, this is from a worksheet on values that's available online through the Happiness Trap. In fact, if you Google the Happiness Trap and worksheet or values worksheets, I believe it comes up pretty readily. So in case you're interested, and also I can share that as well. In terms of acceptance and commitment therapy for substance use disorder, often it does focus on, as we talked about before, accepting urges and then undertaking value-based actions. So again, undertaking value-based actions is all about really centralizing meaning and putting that at the forefront, driving your actions. And in terms of accepting urges, it really is tied in, because it's quite difficult to just accept thoughts and feelings. It's helpful to have that higher purpose that you are serving. When it comes to ACT and OCD, ACT is helpful with exposure work, and they're combined to increase motivation to do ERP by connecting doing ERP to getting closer to those values, to the person that you want to be, and teaching clients that they can have obsessive thoughts and discomfort and still do the things that matter to them. It's really, the focus is more on bringing these experiences along for the ride. From an ACT perspective, the goal of exposure is to learn to interact with feared stimuli in new and more functional ways so that the client can move in the direction of values, the things that are important and meaningful in life, which are currently disrupted. So I want to talk a little bit about why, we are talking through Kennesaw State University. And so the context in which we're speaking is undergraduate education and other education, but many people in late adolescence. And it's important to note that this is a time where meaning and purpose are in flux and being cultivated and created. And it's a central piece of this part of life to better understand and cultivate this sense of purpose and meaning. And actually, studies have found that in this time period, psychological and subjective well-being are connected with a sense of personal meaning. They're correlated, they're positively correlated. And another study found that those who endorsed a greater sense of meaning in their lives were more psychosocially adept than their peers. So there's certainly benefit here from a psychological perspective to supporting meaning in this age group generally. The thing is that in addition to the meaning and purpose being in flux, unfortunately, this is also a period of time when people are more vulnerable to OCD. In fact, this is the second sort of spike of cases of OCD is in this late adolescent period. According to the IOCDF, or International OCD Foundation, late adolescence and early adulthood is one of the time periods when OCD typically first arises. And as circumstances would have it, and probably not terribly surprising to people watching, there's an increase in vulnerability for substance use disorder in that time period as well, in that late adolescent, early adulthood time period. In fact, according to the Diagnostic and Statistical Manual, the onset of alcohol use disorder with 2 or more criteria surges in the late teens to early to mid 20s. So we're really in this vulnerable period here with individuals who are in their late adolescence, where values and meaning are in flux, and also individuals are more at risk for OCD and substance use disorder. In fact, substance use often starts in adolescence and early adulthood and is linked to several physical, psychological, and emotional and social problems. What's interesting is that they have done studies about meaning specifically related to substance use disorder in this population. And what they found is that for people in this population, a sense of meaning and purpose is connected to, or it's indirectly correlated with risky behaviors like binge drinking, illicit drug, and sedative use. So the greater the sense of meaning, the less the likelihood of risky behaviors. And then meaning also seemed to be a protective factor with regard to drug and sedative use, which I think is perhaps the big takeaway here. There's no real drawback generally, from what I can tell, to prioritizing people finding a sense of meaning or prioritizing a sense of meaning and purpose in their lives. I'm sure that, there's an exception to everything, but by and large, that's likely to be supportive of most individuals. And if we could support people preemptively in finding these elements of meaning, it seems that, at least according to this study, it can be a protective factor and help people to perhaps never experience things like substance use disorder. Certainly more research is warranted, and would be great to see that with OCD as well. Ultimately, I want to just share that all of these things that I've been talking about have certainly informed my own recovery. Being of service, trying to do something for other people who are suffering is really meaningful to me, and has not only helped me to maintain sobriety and continue to disengage from compulsions and work toward recovery ongoing for OCD, and it's also imbued the suffering that I've experienced with meaning. In fact, even because OCD is one of those disorders that you're sort of constantly working with, it's managed rather than overcome. I find that when I have the sort of urge or invitation to engage in compulsions, or I'm mid compulsion and I think, should I continue trying to figure this out? I sometimes pause and think, well, but this could be an opportunity for me to learn how to navigate this so that I can better support somebody else. So it really can inform recovery, this idea of meaning and purpose, and specifically service work. Remembering my whys has been central to keeping me active in treatment for both disorders. Knowing that my family and friends are important to me, that I want to travel, that I want to do things with my career and support people. These have all contributed to keeping me on track to doing some of the more challenging things, to not drinking or using drugs when I have the urge to, and ultimately clarifying and prioritizing my values. I know that if I start drinking again, I'm not going to be as kind. I'm not going to be as compassionate with people. I tend to become much more self-absorbed. And I don't want that, because those are really important values in my life. And likewise, I know that if I get caught up in compulsions, I'm going to disconnect from everyone around me. And so that value of connectivity and community really gets sidetracked. So, these are certainly things that have supported me in maintaining sobriety and OCD recovery. And ultimately, like I mentioned before, I think that all of these things have helped me to experience personally meaning and purpose, and have helped me to live a value-driven life, which is inherently very contenting, and much more so than this pleasure principle, which is constantly sort of battering us back and forth between pleasure, pain, pleasure, pain. It's having this greater sense of why leads to greater contentment and meaning and long-term satisfaction overall. So my hope today, I'm talking as part of the Riley's Wish lecture series. And again, thank you so much for having me, Kennesaw State and Riley's Wish. I'm so grateful to be a part of this. My hope is that something that you have heard today, you can take with you and either use it in support of your own recovery if you experience OCD and substance use disorder, or that perhaps you can use it to support the recovery of the individuals that you work with if you're in this field, or perhaps loved ones. Because these two disorders are potentially very damaging and lead to a lot of suffering, and unfortunately are potentially lethal. And so it's really, really important that as you go back out into the community, that if something's resonated here today, I really hope that you'll take that with you and use that to inform your discussions with others and supporting others' recovery or your own. So thank you so much. And I'm certainly open to any questions at this point. I've gone a little bit over, but I can stay after. So I'll sort of let, I guess, Jason come back on and potentially moderate this.
Thank you. I've been keeping an eye on the chat. Was there any questions from any of our attendees? We'll give it a moment.
Yeah, I'd love to answer any questions that you might have. Hi, Margaret.
So with,
Hey,
I'm not seeing any questions, so I know Margaret wanted to come on and say a couple words, so I will be quiet for a second.
Yeah.
You know what? I first want to thank Lauren. We have got to know each other recently and just made such a connection. Her story is similar with Riley's, and she has just jumped aboard and been such a wonderful advocate in helping. And Lauren, be honest, I almost forgot, not that I forgot, but I have not thought about, and I remember I sent you that article way back that Riley had written, and about how that service was so important, and that ties back into the collegiate recovery program. He when he was part of the program, that was part of what they did. And I remember, and, and Jason was at University of Georgia with their collegiate program. Riley actually went with the director, Teresa Johnson, to help get them started. And I think back and I remember how it was so powerful for him that he was able to do that. And that service part of it was just key. And I think, keeping him in recovery for a long time. So thank you for mentioning that. And I think we need to always kind of look back at that. There's therapy and there's, all the things we're talking about, but when you really look at how important that service piece is, when someone starts helping others, it takes away thinking about themselves and worrying about OCD, SUDS. And when they go out and help others, it makes such a difference in their life and for their families. And I just think that's so key.
Thank you for sharing that, Margaret. I had actually forgotten that Riley and Teresa came out there, but I am 100% remembering now. So thank you for sharing that. Thank you, Lauren. We will post the continuing education survey in the chat. We also can hang out for a few minutes as folks grab that survey link. And also if they have any questions, we'll be here for just a moment. So feel free to ask away in the chat. We're at your disposal.
Everybody's quiet.
It would appear that way.
Nice,
And Lauren,
smooth.
I was just going to ask Lauren, how long have you've been in recovery since you were
19.
19?
Yeah.
Okay.
Yeah. So.
And tell a little bit about your story that your OCD wasn't diagnosed for a while.
I think 17 years after the initial onset of symptoms, which I always remember because that 14 to 17 years is the average it takes for people with OCD to get a proper diagnosis or proper treatment. But yeah, no, it's interesting too. Just how much I, like reading a little bit more about Riley and the fact that he was going into graduate school right around the same time that I started. I think there are so many people like us that have these sort of parallel journeys of having OCD and substance use that intermingle. And yeah, I really hope that obviously there's so much that you're doing for the community, and I just hope that work continues. I did just see a question pop on. Not sure if I missed it, but would you recommend any reading materials for those wishing to educate themselves further on OCD and substance use? So there aren't any books currently that address this, unfortunately. Hopefully that will be remedied in the years to come. There's certainly articles, and like I said, I'm happy to share the presentation and all of the resources that I have in there, because there are any number of research articles about, I'm not a ton, but there are some. And I do actually, there's a great article specifically about OCD and motivational interviewing and treating that. Well, actually, that's not about concurrent OCD and substance use disorder, though. It might be. In any case, I'd be happy to, if you want to email in, I'm happy to send over some. Do you guys have anything to add? I don't know if.
Yeah, and I think that's this is kind of a new topic in that within the last 5 to 6 years, people really haven't been talking about it. The OCD community really never talked about it. Riley kind of started at the conference because he was trying to figure out how to help himself. And now with Patrick and Lauren, and Stacy, there's a lot of people that are really starting to talk about it, and there's some statistics out of how many of although I'm not sure they're completely correct, because I think there's so much shame in it that people don't talk about it, but the statistics of how many struggle is probably a little under. So I think, let's see, and I know there's some questions maybe for you, Lauren.
I
think
think
we've covered the questions that were in the chat. So if folks need to head out, feel free to disconnect. We're just going to hang out here. Again, the survey for the continuing education is in the chat. You can click on that. And we look forward to seeing everybody tomorrow at 2 p.m. for our panel discussion. I'll be leading that as the moderator. It will be the lived experience of co-occurring disorders. So we'll be taking a look at a couple different views of that. We'll have somebody with lived experience, somebody who advocates from the community level, as well as somebody who treats individuals in a one-on-one basis. So look forward to seeing everybody at 2 o'clock tomorrow, and enjoy the rest of your afternoon, morning, evening, depending on where you're tuning in from. So thank you all so very much.